In this video, we can observe in real time the distribution of pulmonary ventilation using electrical impedance tomography in a patient with chronic obstructive pulmonary disease who underwent a left single lung transplant. The areas that receive a greater volume, and therefore present higher impedance, are depicted with white pixels, while the areas that do not change their impedance are represented with black pixels. This image corresponds to scenario 1, where the patient is spontaneously breathing through the tracheostomy cannula without high-flow oxygen therapy. It can be observed that the native lung, the right one, receives the highest percentage of pulmonary ventilation. In the right side image, changes in impedance over time are graphed. The black line represents the global impedance, the red line represents the impedance of the native lung, and the blue line represents the transplanted lung. It can be observed that when the transplanted lung completed its emptying, the native lung continues to exhale, indicating the presence of elevated expiratory time constants. Now we are observing the same patient with the application of high-flow oxygen through the tracheostomy. It can be observed that the native lung still has the highest representation of impedance or volume. In the graph on the right, the red line, representing changes in impedance in the native lung, is higher and has higher time constants compared to the previous scenario. These changes highlight the increase in tidal ventilation in the native lung, with an increase in expiratory time constants due to tidal hyperinflation. In this last scenario, we can observe pulmonary ventilation when the tracheostomy cannula is occluded, and high-flow oxygen is applied through a nasal cannula. The first thing to notice is the decrease in respiratory frequency compared to the previous scenarios. The changes in impedance still remain higher in the native lung, with no significant changes in the transplanted lung. In the graph on the right, there is an increase in the vertical axis of the red line, corresponding to the increase in end expiratory impedance, and an increase in the horizontal axis due to the prolonged lung emptying time. It can be observed that despite the decrease in respiratory frequency and consequently an increase in expiratory time, the native lung, represented in red lines, does not complete its lung emptying before initiating a new inspiratory cycle. In conclusion, the application of high-flow oxygen via tracheal or nasal route in this patient resulted in pulmonary hyperinflation due to air trapping in the native lung, with no benefit in the transplanted lung. This effect was more pronounced when using high-flow oxygen via nasal route. Electrical impedance tomography is a valuable tool for physicians in monitoring regional ventilation in patients with varying lung compliance in each lung. By utilizing electrical impedance tomography, physicians can accurately assess the ventilation patterns and make informed decisions regarding the most suitable therapeutic option for these patients.